Bom dia.
Hi, good morning, Alex. Bom dia, Eberhard. Nice cases. I was hearing from here. Well, let me start showing my partners here on my right side. That is Rodrigo Costa. On my left side, Raul Arrieta, who's going to put the device in. And we have Simone Pedra there on echo doing the TE. John Sheeran couldn't make it, so that's okay. So before we start, let's show the case, the slides, please. Yeah, next one. This is a 17-year-old male weighing 71 kilos. He had a previous diagnosis of coarctation and a perimembranous VSD. In his past history, the coarctation was repaired at the age of 5 years, and because the VSD was deemed very small, it was left alone. He then went on with mild requartation with controlled blood pressures on medications until the age of 16, when his referring physician felt that coarctation should be addressed. So he was referred for coarctation stenting in September last year. I'm going to show you the pictures in a minute. And unfortunately, in February this year, about 2 months ago, he had endocarditis, which responded very well to a prolonged course of antibiotics. This patient has been asymptomatic with normal blood pressures on no medication. He has a typical murmur of a VSD, and on echo he has mildly enlarged left ventricle. And because of that, because the previous episode of endocarditis, he was referred for perimembranous VSD closure. So next slide. This was the requartation. We did that in September last year. Was not very tight. Was a mild quartation. Next one. And this, after stenting, he had about 20-25 millimeters of gradient before stenting. There was no gradient afterwards. As you can see, the left subclavian artery arises from the point where the coarctation was. So this, the stent is straddling the origin of the left subclavian artery. Next one. So this is the echo of the VSD, short axis, shunting left to right. Next one with color flow Doppler. Próximo. Again, this is 4-chamber view. This is a big guy, 17. And as you can see on the right side, there's a little bit of tissue sort of around the VSD. Next one. These were the measurements, anywhere between 5.5 and 7 millimeters in size on TTE. Next one. Again, there is a high gradient across the VSD, which means that we have low PA pressures. Next one. And this was, again, for chamber view, showing a mildly dilated left ventricle. Next one. And on echo, the side of the stent, there is no flow acceleration, no gradient, and the Doppler in the abdominal aorta was normal. Next one. So the intended intervention here is to close this VSD by percutaneous means. So any questions, any discussions regarding the indication of this intervention?
No, I think the indication for close this perimembranous VSD is due to the endocarditis. And I would like to see the angio.
We haven't seen the angiography.
Carlos?
Yeah, we're going to show that. Let's show the angio, guys. There you go. So this is, let me show the first angio here. Of course, we took a look at the stent. There is good apposition. There is no gradient. In fact, we had like a 3 millimeters gradient. There is no aortic wall abnormalities. We always take a look at those stents after anywhere between 6 and 12 months. And after we did that angio, this kid had an anaphylactic reaction with very low blood pressures. We had to give him a lot of fluids and some drugs as well, epi, in order to keep him going. So this is the angio, the LV angio. As you can see, the heart rate was up a little bit because of epi. And it's a small VSD. We measured here, we're going to see on echo in a minute, it is a small VSD. We measured about 5 to 6 millimeters, so I think that was the right thing to do long time ago, to leave that alone. But now it's a different story. I would like to show you the TE pictures. Simone is going to go over those pictures.
Carlos, the main
go
indication.
ahead, Simone. Echo, please.
Carlos, the main indication.
Yeah, just a sec. Yeah, go ahead, Eberhard.
Yeah, the main indication for this pressure separating VSD is the risk of endocarditis in this situation.
Yeah, he had endocarditis, right? He had endocarditis about 2 months ago.
Mm-hmm.
So, and there are some interesting findings on echo because of the endocarditis, and Simone will make some comments upon that. Go ahead, see.
Okay, so starting in the long axis view, as we see here, we can see the aorta and the defect. It's a perimembranous outlet VSD, and this is the orifice in the left side, and we can see some thick tissue around the defect here, and with some echogenic aspect because of the previous endocarditis. And looking at with color flow mapping, as we can see here, you see how it's a left to right shunt at the VSD level. This is the short axis. You see the tricuspid valve here, and we see the VSD in this area here. Let me show you some more pictures. Just a sec. Here we measured. Here we got, in the long axis view, about 4 millimeters, 4.1 millimeters. And then with color flow mapping, this outflow area in the left side was about 4, and then it's a little bit larger in the middle of this tunnel. And here, about 4 millimeters. Then we got some 3D pictures. I like to show you. It's not this one. Just a sec. Here. So here, you can see in the 3D pictures. This is the aortic valve, and this is the orifice. When the orifice here. This is the left side of the orifice, and this is the right side. You can see the tissue around the defect here. It's accessory tissue and a little bit of fibrosis around the VSD. And then we got some measurements using the 3D, and we measured about 6 millimeters here in the left side of the defect. So I think that's the main pictures I like to show.
Nice
sort of a windsock appearance. Yeah, very, very nice pictures. And it does have this windsock appearance with some hyperechogenic appearance on the left side due to the previous endocarditis. So any questions so far? I'm going to show what we've done until this point. Any questions from the panel?
Carlos, I have a
Let
question
me show the angel, please.
from a non-congenital guy. So what is the criteria to intervene, Carlos, in terms of size, in terms of measurements? Simone says it's 6 millimeters. Is there any cutoff value to intervene or not, or this is based on the shunt, or there is any other parameter? Again, this might be a
very good question. Yeah, we have to intervene in any kind of perimembranous VSD when the LV is dilated. So this is the marker of the indication for intervention. intervention. But this guy had like borderline left ventricle, and because he had a coarctation before, so I think the decision to leave that VSD alone at that time was right. But now it's a different story, right? Because you have a little bit of borderline left ventricle, and he had endocarditis. So I think these should be closed. If he hadn't had endocarditis, I think everybody would have agreed to leave this VSD alone. I think this is the bottom line. So the endocarditis changed our decision-making process here. So let me show you the angels, please. Hemodynamica.
Okay.
I've heard, there you go, it's back. Yeah, we crossed this VSD, in fact, very easily with the 4 French JR catheter. We managed to slide a 014 wire, a coronary wire through it. So we went to the RV, we changed that 014 wire for 032 wire. We tried to advance that wire through the snare. We couldn't do that using that view, so we had to go PA, and we placed the wire in the right pulmonary artery and the snare in the right pulmonary artery, as you can see there. And then we managed to grab the snare to the wire using a snare. We pull everything back, and then we created an arteriovenous loop going from the artery on the left side and exteriorizing the wire in the vein on the right side. And then by doing that, we had lots of support to advance 7 French long sheath that you can see here, sort of kissing the 4 French JR catheter that was passed through the VSD and went all the way down to the IVC. So then, after creating the loop, we tied both sides of that loop, and then we advance the sheath and pull back the catheter, so we went through the VSD very easily. So this is the way to have support to advance the sheath. And then on this picture here, in this picture you guys are seeing some pullback of the dilator inside the sheath, and we create a little gap between the catheter and the sheath, and by doing that we advance the wire. As you can see, it went easily through the valve. We were kind of lucky because the aortic valve